special.
वेरी गुड इवनिंग टू ऑल. नमस्कार सभी को. आज के इस कार्यक्रम में कार्यक्रम का ये उद्देश्य ये है, लेट रिस्पेक्टेड प्रोफेसर प्रेमवती तिवारी मैडम के स्मृति के उपलक्ष्य में आयुष दर्पण फाउंडेशन देहरादून उत्तराखंड इंडिया के द्वारा आयोजित इस व्याख्यान माला में आप सभी का मैं वैद्य शिल्पा यरमेत पाटिल सोलापुर महाराष्ट्र से बहुत बहुत स्वागत करती हूँ. आज हमारे साथ उपस्थित है वैद्या ईना शर्मा मैडम, जो कि सीनियर रिटायर्ड प्रोफेसर है. तो इस कार्यक्रम में हम लोग सबसे पहले तो भगवान धन्वंतरी की वंदना से we will start this lecture series. So I welcome you all in this lecture series on behalf of Ayush Darpan Foundation. So let's pray Lord Dhanvantari.
शंखं चक्रं जलौकां दधतमृतं घटं चारुदौर्भिश्चतुर्भिः सूक्ष्मं स्वच्छातिरुद्यं शुकपरिविलसनम् मौलिमम्बोजनेत्रं कालाम्बोद्योज्ज्वलाङ्गं कटितटविलसश्च चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तव निखिलगदमिव प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्.
So once again, I welcome all of you in this lecture series. Professor Respecter स्वर्गीय डॉक्टर प्रेमवती तिवारी जी के उपलक्ष्य में हमने इस कार्यक्रम का आयोजन किया है. एंड आज हमारे साथ उपस्थित है रिटायर्ड प्रोफेसर डॉक्टर ईना शर्मा मैडम. आई वेलकम यू मैम. आर यू देयर मैम? डॉक्टर ईना मैम, आर यू देयर? Yeah. By which name, ma'am? Just put in the chat box, so I will make you the co-host. Yes, ma'am. I think you can unmute yourself now. So let me introduce first Vaidya Professor retired Dr. Ina Sharma ma'am from Government Ayurved College, Paparola. Madam has worked in this field around 40 years long. So ये हमारे साथ आज डॉक्टर ईना शर्मा मैडम जो उपस्थित है, तो काफी एक्सपीरियंस्ड पर्सन है. उन्होंने करीब 40 से ऊपर स्टूडेंट्स को भी एनलाइट किया है और गाइडेंस दिया है. तो अ वेरी वेल नोन एंड रिस्पेक्टेबल प्रोफेसर इज हियर विद अस. फर्स्ट आज का ये हमारा व्याख्यान है और ये इस फर्स्ट व्याख्यान में उपस्थित सभी जो भी उपस्थित सारे ऑलराउंडर वैद्यास है जो आयुष दर्पण प्लेटफॉर्म इंटरनेशनल प्लेटफॉर्म है. दिस प्रोग्राम इज लाइव ऑन आल्सो आयुष दर्पण डिजिटल प्लेटफॉर्म, फेसबुक also, and it will be uploaded on YouTube also later on. So it's live also Facebook. तो इस कार्यक्रम में उपस्थित सभी वैद्यों का फिर से एक बार स्वागत करती हूँ और वैद्या ईना शर्मा मैडम को यहाँ पर मैं आमंत्रित करती हूँ, वो अपने व्याख्यान का आरंभ करें. Yes, ma'am. You can continue.
Thank you, Dr. Shilpa.
And today's topic is, I think, a very much important topic. So pregnancy related problems are there which are having a wide importance in the field. Many patients came with the various type of complaints. So ma'am, please.
तो सबसे पहले तो मैं आयुष दर्पण टीम का धन्यवाद करूंगी, जिन्होंने मुझे इतने माननीय, इतने रिस्पेक्टेबल मैडम, पूजनीय मैडम पीवी तिवारी जी के यादगार में जो लेक्चर सीरीज शुरू की, उसमें सबसे पहला मौका मुझे ही बोलने का दिया। बहुत ऐसी शख्सियत जिनके बारे में शायद शब्द हैं ही नहीं, उनकी महानता को व्याख्या कहने के लिए शब्दों की कमी पड़ जाती है। सबसे पहले तो मैं आप सबका धन्यवाद करती हूँ और अपनी गुरु मैडम पीवी तिवारी जी के चरणों में श्रद्धा सुमन अर्पित करती हूँ। और उसी के साथ आज अपना मैं टॉपिक शुरू करूंगी, आइडेंटिफिकेशन ऑफ हाई रिस्क प्रेगनेंसी। ये टॉपिक मैंने इसलिए लिया है बिकॉज मैडम की ही शिक्षा थी, उन्हीं की दी हुई ये ज्ञान था कि जब तक आप डायग्नोज अच्छे से नहीं कर लेते हैं, कुछ भी करने का औचित्य नहीं है। तो सबसे पहला काम तो ये है डायग्नोसिस, डायग्नोसिस, डायग्नोसिस और डायग्नोसिस, निदान आपका it should be always right. Then only you can enter into the treatment line. Treatment is not that much important as much as diagnosis. So let's go ahead. As all of us know, normal pregnancy is just fusion of spermatozoa with ovum, which is known as fertilization basically, but commonly it is known as pregnancy. Ayurveda added in it Shukra, Shonit and Jeev. So when the life is there in it, only then it is called pregnancy. And the total duration of normal pregnancy is 280 days, 40 weeks, 10 lunar months, and 9 calendar months plus 7 days. This is very clear. And uneventful pregnancy is called normal pregnancy. Now, what is high risk pregnancy? Let's go ahead with first, what is high risk pregnancy? Then only I will go ahead with the identification process. As all pregnancies are always at risk, किसी भी समय पे, कैसे भी, कहीं पे भी कोई भी दिक्कत, कोई भी मुश्किल आ सकती है during pregnancy. But the definition of a high risk pregnancy is basically, high risk means when the health of fetus and mother both are on risk. When pregnancy is complicated by one or more factors which adversely affect the mother or fetus, where morbidity and mortality of fetus and mother can be there in the antenatal period, in the natal period, or in the postnatal period also. So that is why high risk cases require more attention. Incidence of high risk pregnancy in India, it is around 20 to 30%. And we can see the severity, we can see the emergency, how much important is this, because these 20 and to 30% pregnancies are responsible for 75% of prenatal morbidity and mortality. So which are the factors which make pregnancy high risk? These are few physical characteristics, few social characteristics, pre-existing health conditions, pregnancy-related health conditions, pregnancy-related in previous pregnancies and in present pregnancy also, and exposures that can harm fetus. Now, physical characteristics, as you know, age more than 35 or 35 plus, especially if she is primary gravida, she is always at risk. Even if she is a multi-gravida, she is at risk, because pre-existing disorders, whichever is present, can increase the risk during pregnancy. Preeclampsia, gestational diabetes can be there. Chromosomal disorders can appear like Down syndrome. Stillbirth or intrauterine growth restrictions can be there, and APH due to placental attachment, that is placenta previa, or due to detachment of abruptio placenta can be there. And if it is below 19 years or adolescents in pregnancy in adolescents, that is again at risk because of anemia. It's a very common thing in our India, especially. Preterm labor can be there because uterus is still, the organs are not prepared to handle all these things. Preeclampsia can be there, and high risk of STDs and IUGR can be there. This is because in below 19 years of age, because they don't know what can harm them, what type of behavior of these girls or say these ladies can harm them. So they keep on going with the eating habits, with the lifestyle, whatever they are following. And lack of medical attention also can be there. Ignorance can be there, which is responsible for this type of disorders. Then weight. In women, as said in Ayurveda in general, बहुत ज्यादा कृश और बहुत ज्यादा स्थूल दोनों ही they are निंदनीय हैं. The same thing applies here. Thin women with BMI less than 19.8 or weight less than 50 kg will have underweight babies. And overweight women, which have those who have BMI between 25 to 29 before pregnancy, and obese women with BMI more than 30 will have large or small for gestational age babies. Preeclamptic, they can be preeclamptic, and they can have gestational diabetes, they can have hypertension, they can develop, and because of obesity itself is a big obstruction during labor. Then height, if it is less than 5 feet, say 4 feet, 10 inches or 11 inches or like more less than that, they will have definitely a small pelvis. So they are at high risk. They will have obstructed labor because of pelvic abnormality. They can have preterm labor because nature always prefers to take out the baby from the vaginal path. So the nature will like to deliver the baby preterm because the baby will be of lesser weight. So the baby will be at risk now. Structural abnormalities in uterus and vagina. It's like, I have not written everything here, like double uterus or large with fibroids, or if some septum is there or incompetent cervix is there. So these can be responsible for miscarriage or abortion, for preterm labors, or for abnormal presentations. Then social characteristics. Social characteristics are unhealthy diet. It can be in a poor class, it can be in a higher class with affording patients. बहुत अमीर और बहुत गरीब दोनों में भी unhealthy diet का schedule हो सकता है. Unprotected sex, that can also be there everywhere. Less medical care if we are not very cautious about that, and lack of awareness. These are the social behaviors which are leading to say high risk cases. Common pre-existing medical risk factors जो कि पहले से उसमें मौजूद हैं, जो कि प्रेगनेंसी से पहले उस औरत में हैं, उस लेडी में हैं. So these are autoimmune diseases such as lupus or multiple sclerosis. If she is diabetic, already diabetic, that is going to enhance, the lady can be put on risk if it is uncontrolled. High blood pressure, if she's having and it's not controlled, she can be at the risk to have preeclampsia. HIV or AIDS, if she is having, she is already immunocompromised. Renal diseases, if she has, or she has some type of renal infection is there, if renal disease is there, she's likely to have preeclampsia again. And if some renal infection is there, which is continued, and she will be likely to have anemia. And then if some cardiac problem is there, all of us know, because cardiac output is cardiac load is increased in pregnancy. So if cardiac problem is there, that is going to enhance. And obesity is there. Obesity is a very big factor. It can lead to so many diseases itself, and obesity can be a factor for in the time of labor also, which is causing, say, this obstruction in normal labor. Then thyroid disorders, if they are there, baby may be mentally compromised if it is not treated. If treated, okay. Then blood clotting disorders, if they are present, a lot of bleeding can be there. Sickle cell diseases, if they are there, so anytime this can be thrombus formation can be there, and in late pregnancy, bleeding disorders can develop, and during the labor, more of the bleeding can be there, and BPH can be there because of the sickle cell disease. Then if these are STDs, if they are present, the baby is always at risk, especially in syphilitic patients. Baby can be, say, IUD can be there after the 8 months of pregnancy. And new disease which has come up, COVID-19, if it is there, she's having before pregnancy or during pregnancy, she may be at risk. We take it as risk because it's gives high grade fever. The drugs which we use can be, say, teratogenic to fetus, and if high grade fever is there, that itself is a cause of, can be a cause of abortion, can be a cause of IUD, anything. But as such, if COVID-19 virus is going to do something, it's not clear right now. And problems in previous pregnancy, if they are there, like small or large for gestational age babies. Baby, she can be a diabetic patient. If she's a diabetic, large baby can be there, or sometimes small for gestational age baby. If there is intrauterine growth restriction is there, then miscarriage can be there, antepartum hemorrhage due to the placement of placenta, कभी उसको placenta previa था या abruptio हुआ, sometime abruptio can be an accident only. Placenta previa can be due to the shape of uterus, due to the shape of pelvis, it can be there. So placenta doesn't find the space for an attachment in the uterus on the upper segment, so it goes and attach itself in the lower segment. So these are in the previous pregnancy. If it says a risk is there, she can have in late second pregnancy also. Preterm or post-term delivery, if the history of it is there, prolonged or obstructed labor history, that means pelvis is not, say, good. RH incompatibility, if it is there, so definitely it's on, she is on risk. Polyhydramnios or oligohydramnios, both are the things which are at risk. Polyhydramnios, baby is somewhere compromised, somewhere maybe having some problem, and oligohydramnios again is the same thing. The baby may be having some problem, and again the baby can have congenital deformity also. Some structural deformity can be there also. Abnormal presentations, if they were there, that shows something may be wrong. Like abnormal presentation normally are caused by the pelvic shape, or sometimes because of the uterine shape, or sometimes it can be due to the placental attachment, it is there, or the baby was very big, or so, or it was a preterm labor. So at that time, preterm labor, because this presentation is not fixed at that time. So it can be that at the time of delivery, some abnormal presentation can be there, or there were twins, one was normal, one was with the cephalic, one was with the breech, or something else, anything else can be there, with transverse can be there. Ectopic pregnancy, if it was there, she is likely to have in another tube also. Stillbirth, if it was there, then we must have to see the reasons why it was there. Multiple birth and syncope, etc. All are the things which has to be seen for, because if they were present in previous pregnancy, we have to be very careful to look into this pregnancy. Then exposure during pregnancy to the infections like viral infection, any type of viral infections, Zika virus, and say this COVID-19 virus, you can say, or other viruses, any type of viral infection can be there. And bacterial vaginosis, if if she's exposed to that, she's at risk, the baby is at risk. And if the torch is there, that is toxoplasmosis, rubella, cytomegalovirus, herpes, if anything is there, she is at risk. She may have abortions, she may have stillbirths. Drugs like alcohol, cocaine, tobacco, if she is consuming those drugs, the baby is also exposed to that. So definitely the baby is at risk. Radiation, repeated X-rays. Previously, we were used to go for X-rays. We have to, because we didn't have this ultrasonography facilities at that time. So normally it was avoided in first trimester. Still, it is avoided in first trimester because of teratogenicity. So radiation exposure is again the baby. We are putting the mother and baby on risk. And similarly with the chemicals, so many chemicals, any chemicals, if we expose them, they are at risk. And potential complications of high-risk pregnancy are, if we, in nutshell, we see into this thing, the high-risk pregnancy can be life-threatening for the pregnant lady or unborn baby. So these complications are preeclampsia. This is high blood pressure from pregnancy, edema, and then eclampsia, seizures. If it leads to, if the preeclamptic state is not controlled, if it is avoided, if it is not seen, so at that time she may enter into the eclamptic state. Then preterm delivery, excessive bleeding during labor and delivery or after birth, low or high birth weight babies can be the outcome. Birth defects can be there. It can be congenital. It can be some structural abnormalities because of the oligohydramnios or like that. Then problems with baby's brain development if thyroid is overlooked, miscarriage, stillbirth, and operative delivery can be. You have to go for operative delivery in case we don't take care of this thing. And how can we prevent the high-risk pregnancy, we should say? The risk can be reduced by providing prenatal counseling. Prenatal counseling, why it is important? Because as we said, before pregnancy, what the lady is having, even if she is having diabetes, she is already hypertensive, she is having some type of, she's having anemia, severe anemia. She is at the time of pregnancy, if she is having jaundice and she conceives at that time, or such type of problems if she is not consuming proper diet, not nourishing diet. So all these things are to be considered. So prenatal counseling, whether she should go for pregnancy this time, she should go for this fertilization this time or not, she should try for that or not, or she should withhold the things, postpone the things. And good antenatal care is very important thing. And good antenatal care itself brings out the identifying potential health risks before getting pregnant and managing any pre-existing health conditions. So one aim of antenatal care is to identify impending complications and manage them to reduce morbidity and mortality. Now, how can we identify? This was about in brief, it was about what is high-risk pregnancy and why it happens, what may be the cause, what are the predisposing factors, we discussed about that, and how can we identify the patient, whether she is at risk or not. Right from the beginning, once we start the history taking, which normally this is for students particularly, because most of the time students take a shortcut for history taking, which is very, very dangerous for the patient, for the diagnostic point of view, for the doctor, as far as doctor is concerned, and for the line of treatment, what is to be given. So we have to take care of when taking the history. Then during examination of patient, right from the time when the patient enters in your room, where your examination starts. During laboratory investigation further, and then examination of pregnant women during labor and after delivery also. So what are the points to be taken during history taking, specifically in obstetrical cases? We go for general history. General history, usually we ask about the age, as we discussed previously. Like right now, I told you, if it is less than 19 years, or say adolescent pregnancy, or if it is more than 35, after 35 years of age, it should be taken as high risk. So first of all, we go for the age of the patient. Then socio-economic status. Though once the when the thing comes socio-economic status, we say poor patients maybe are at risk because they are not getting proper diet, right? They may not be able to provide it proper diet, or say nourishing diet or balanced diet to the patient. But in higher income group also, there they are not taking the proper diet or nourishing diet deliberately. Once because of our taste, we go for that. Once because of our fashions, we go for that. So it has to be seen. So socioeconomic status is important to know, because of if she is a poor lady, or she doesn't have the access to the right type of food, we can think she can be anemic, and because of these deficiencies, she may be having some structural abnormality also, or some she may be having some say medical problem also. So it has to be taken care of. And in higher income group also, it can be there. We should take care of that also. Number of pregnancies and parity. If she's a primary gravida, definitely she can be at risk. She is at risk. Why she is at risk? Even if it is a normal pregnancy, because she is mentally so much in anxiety. She is in an anxious state. That anxious state has to be tackled on. Whereas as far as parity, multipara is concerned, definitely she is an experienced lady now. She knows what is to be done or what not to be done, what type of problems are not good for her, when she has to attend the doctor. But if the parity is more than 3 or 4, again, she is at risk. She may enter into, even if she had normal deliveries, she may enter into the operative delivery because of the laxity of the muscles, of the abdominal muscles. Abdominal support is not there. And moreover, if she is a multipara, she is likely to have anemia. She is likely to have deficiencies now. Then any history of recurrent or habitual abortions is there. She is definitely at, we have to think of on why abortions were there. History of any intrauterine death or stillbirth is there. History of obstructed labor is there. That could have been due to the size of fetus. That could have been due to the size of pelvis. That could have been because of any diabetic status, or that could have been because of the anemic state also, because the lady is not of that say capability. She is not able to say आपका वो साथ नहीं दे सकती है, आपका कर नहीं, सपोर्ट नहीं कर सकती है. She cannot cooperate because of her health status. Then history of cesarean section or other surgeries there. If cesarean section, if it is less than 3 years gap is there, then we should think of this thing for a second time cesarean section. First thing is, we have to see why cesarean section was there. Whether it was a planned section, whether it was an emergency section, and why it was there, the reason has to be seen. And if the gap is less than 3 years, we should consider cesarean section. Even then, we have seen the cases where even after 1 or 2 years, patient has delivered normally, but she has to be taken care of seriously. And if other type of surgery, abdominal surgery is done, again, we have to be really careful about that. Then history of other systemic diseases like diabetes, hypertension, etc. History of recurrent early rupture of membranes. In the previous pregnancies, there was the history of मेरी तो थैली पानी की जल्दी फट जाती है. So it can be there in the cephalopelvis, say, and posterior position, cephaloposterior position. It happens. It can happen. Large size of head. It can happen. When the head is trying to come into the pelvis, but it is not able to enter in the pelvis, bag of membranes will come first and rupture in the first stage. Early rupture happens. So we have to take care of that thing. Why it happened? What was there? Then recurrent preterm labor history is there. Then we can see there can be some cervical incompetency can be there. Because of that only it is happening. Babies, history of babies with congenital deformities, if they are there, or diseases. So we have to, they are definitely they are at higher risk when we have to see that the baby can be like that because it is a genetical problem. And chief complaints. Once we ask for chief complaints to the patient, she comes to you with the excessive vomiting. Normal nausea, normal vomiting is, we should consider that, but excessive vomiting is there. We normally, what happens when the pregnancy patient comes, we say, okay, because of pregnancy, it may be happening, so especially once she is in first trimester. But we have to see, we should look for any appendicitis is not there, if then some abdominal pain can be there, no, is not there, acute abdomen can be there, or if sometimes some renal problem can be there, which is leading to this thing. So every factor has to be taken care of. It's not necessary we should tell to the patient, तुम्हें ये भी हो सकता है, तुझे ये भी हो सकता है, डराने की जरूरत नहीं है पेशेंट को, but we should consider ourselves कि और क्या क्या कारण इसमें हो सकते हैं, where she can be at high risk. And because of excessive vomiting, she can be dehydrated anytime. So we have to see that also. Then if she is having severe headache, she complains of severe headache. Every time मेरे को बहुत ज़्यादा सिर में दर्द रहता है. Maybe she is having lack of sleep. Maybe she is very anxious about that, about pregnancy. She is worried about that. And maybe she is hypoglycemic every time. She is not taking her food properly. उसको उल्टी होती है, उसको नौजिया होता है, वो बार बार अपना खाना नहीं खाती है ठीक ढंग से. So we have to guide her for that purpose. कि आप थोड़ा देर में, थोड़ी देर में कुछ liquid diet लेते रहें, so she can be have nourished type. और उसके अलावा we have to see for hypertension also. पे blood pressure तो वो हमको देखना है. She can be hypertensive, she can be hypotensive also. उसका बहुत ज्यादा blood pressure कम जा रहा है, खाती नहीं है, उसकी वजह से उसको सिर में भारीपन रहता है. Then chest pain can be there. Chest pain can be simply because she can say कि मेरे को दर्द होता है जी, दर्द होता है, that can be simply because of gastritis. But again we have to take care of any cardiac issue if she is having, or then excessive dizziness if she complains, बहुत ज़्यादा चक्कर आते हैं. Again blood pressure has to be monitored, renal case, all investigation has to be monitored. And pedal edema or anasarca, she is having edema feet, that can be a simple thing. बहुत ज़्यादा anemic है, dependent part का anemia can be there. But again we have to look into it. If that edema will continue, that may lead to preeclamptic state. So we have to teach the patient at that time, so she may not enter into the high risk case. उसको अपना पैर लिफ्ट करके रखो, उसका एनीमिया का स्टेटस देखिए कैसा है, क्या है, and we have to improve that with the diet and drugs. Then anasarca is पूरा body में edema हो गया है, so definitely she is at risk. Then blurring of vision in severe hypertension, it can be there. Blurring of vision can be there definitely. And preeclamptic state, it may be entering into eclampsia. If high grade fever is there, the baby is at risk. High grade fever में उसको blood supply जाना कम हो जाएगा, blood supply जाना कम हो जाएगा तो baby को oxygen की deficiency में ही baby में be compromised. Then convulsions are there. If she is entering into the, she may be entering into the eclamptic state, syncope, because बार बार बेहोश हो जाती है. Why it is there? कभी कभी I have seen once or twice a case of eclamptic cases also in life, because we are working in a very rural areas I work. तो वहां पे I have seen the patient, they came with the, ये तो चूल्हे पे रोटी बनाती बनाती बेहोश होके गिर पड़ी थी. So once we saw the patient, she was severely pre-clamped. उसका पूरी body NSR का, anemic, hypertensive, everything was there. So we have to see, we should not avoid that. We have to teach them also again. Then severe pain abdomen is there. Severe pain abdomen, normally भी pain हो सकता है पेट में से GIT की वजह से हो गया हो, लेकिन ectopic pregnancy, rupture तो नहीं हुआ, कहीं ectopic तो नहीं है उसको, we have to see that also, and other reasons also should be excluded. Bleeding per vagina with or without pain. So it can be APH, antepartum hemorrhage. She may be entering into antepartum hemorrhage in late pregnancy, and if it is in early pregnancy, she is leading towards miscarriage or abortion. Then fetal movements, if they are increased or decreased. Decreased, definitely you say कि decrease कम हो गया तो बहुत dangerous है, but increased also, suddenly increase हुआ और उसके बाद decrease हुआ. Sometimes what happens, लंबा cord है, cord around the neck आया, and what happens, जैसे कह लीजिए कि किसी को फंदा लगा देते हैं और वो तड़पता है, like that same status comes, एकदम इंक्रीज होगा मूवमेंट अपने आप को बचाने के लिए, एंड सडनली दैट ड्रॉप्स डाउन, डिक्रीज हो गया. सो उसको वी शुड टेक केयर ऑफ दैट सीरियसली, इमीडिएटली. द बेबी मे बी सेव्ड विद द सीजर्स एंड ऑल. Passage of amniotic fluid or meconium through vagina, if it is there, that's definitely the patient, the baby is at risk. Then during examination, what we find, general examination, presence of bony or structural deformities. जब पेशेंट आपके पास चल के ओपीडी में आता है तो उसके समय आप देख सकते हैं कि अगर कोई इसको बोनी डिफॉर्मिटी है, वी कैन मेक इट आउट कि उसके लेग में कोई डिफॉर्मिटी है. शी मे बी एबल टू deliver normal or not, she may be having normal pelvis or not, we can see there itself. Very lean or obese patients, I have already discussed about these things. Presence of signs of anemia, we should say look into it. Anemia है और बहुत ज्यादा अगर उसको है ऐसा, तो राइट नाउ आप उसको उसी समय डाइट प्लस मेडिसिन से उसको ठीक करेंगे. प्रेजेंस ऑफ साइंस ऑफ जॉन्डिस, इफ इट इज देयर, जॉन्डिस का भी अगर साइन है तो अगेन बेबी मे बी कॉम्प्रोमाइज बिकॉज ऑफ जॉन्डिस. बेबी को साथ साथ माँ को भी उसका मोर्टेलिटी कैन बी देयर इफ सीवियर जॉन्डिस इज देयर, इफ इट इज नॉट कंट्रोल्ड. Then pedal edema or NSR ka already I have discussed. Rise in blood pressure, if it is more than 140 and over 90 mmHg. Nowadays we say is this 30 plus, we say take. But excessive weight gain, especially after 28 weeks of pregnancy, suddenly वजन जो है वो ज्यादा बढ़ना शुरू हो जाता है. एक महीने में डॉक्टर साहब मेरा 3 किलो 4 किलो वजन बढ़ गया. So it's a dangerous thing. We have to see. Patient नहीं समझ रहा है, उसको लगता है कि मैं मोटी हो रही हूँ, but definitely she is developing edema overall. She may be developing, उसका develop हो रहा है, उसकी वजह से ये weight gain हो रहा है. That has to be looked after. Then signs of uncontrolled diabetes or other systemic diseases, we should see. If abdominal girth is more than amenorrhea, बहुत बड़ा है पेट का, जितना हम साइज देखते हैं बिगिनिंग से ही हम देख रहे हैं, तो बहुत अर्ली प्रेगनेंसी में वी कैन थिंक ऑफ herpetiform moles, if they can be there. And if it is in late pregnancy, the big size of baby can be there. Polyhydramnios can be there. Then abdominal girth is less than amenorrhea period. Again, baby is not maturing right, and they're not growing rightly. Compromised baby हो रहा है. और अदरवाइज दूसरी चीज, एक चीज और ध्यान में रखनी चाहिए इसी के साथ, डेफिनेटली वी हैव टू थिंक, बिकॉज वी आर टॉकिंग अबाउट द रिस्क फैक्टर, सो वी आई एम टॉकिंग अबाउट दैट. बट इफ द गर्थ इज लेस और गर्थ इज मोर, मे बी हर LMP, वी हैव टू एश्योर द थिंग, जो उसका LMP बताया है वो ठीक है कि नहीं. समटाइम्स व्हाट हैपेंस, प्रेगनेंसी LMP आज बताया उसने February में, but she had a period, missed period in March, but there was no pregnancy. After that she became pregnant. So in her opinion 2 महीने निकल गए, but the pregnancy was of only 1 month. So that has to be excluded definitely. उसको देख के, और उसके लिए आजकल हमारे पास साधन अल्ट्रासोनोग्राफी is there. And sometimes what happens, pregnancy उसको fertilization हो गया, लेकिन उसके बाद उसको स्पॉटिंग हुआ एंड शी टुक इट एज कि 1 या 2 दिन के लिए ब्लीडिंग हुई, तो दैट वाज बिकॉज ऑफ so I had a normal period, but pregnancy was there. So we उसके हिसाब से भी 1 महीना हुआ, but with our own opinion, if we go for that, it's of 2 months. So we have to assure that also. Fetal movements not palpable. If it is not palpable, we have to take care. Go for not today we can go for ultrasonography. We can go for fetal monitoring, electronic. Fetal head size abnormally big. If it is very big, so this hydrocephalus can be there. Or in IGR cases, few IGR cases, size of head can be bigger than body. Harder fetal head is there. Harder fetal head tells the story of it can be a postpartum pregnancy. Multiple fetal parts palpable, multiple pregnancies can be there. Abnormal presentations and positions, if we find, we have to go for, again, we have to look into the case whether this cephalopelvic disproportion is there, and that can be because of the pelvic factor, that can be because of the fetal factor, and that can be because of the placental factors also. Abnormal this non-engagement of presenting part after 34 weeks in primary gravida, if it is there, we should look into it. So we find the cases to nowadays, even if after 36 weeks of pregnancy, after 37 weeks of pregnancy in primary gravida, we find this thing that is engaged normally and patient delivers normally. But we have to be very careful if it does not engage after 34 weeks. Irregular, decreased or increased fetal heart rate is there. Then comes to the pelvic examination. If cephalopelvic disproportion, we find the head is not entering in the pelvis at the right time. Borderline or contracted pelvis is there. Incompetent cervical os history is there, or we find it there. Leaking of amniotic fluid per vagina is a high risk. Patient, if it is in the first stage of labor, patient may enter into the more chances are she is entering for operative delivery. Bleeding per vagina is there. There can be a local lesion, and there can be say placenta previa, there can be vasa previa, some vessel is coming in front of it. So again, we have to take care of these things. Then laboratory investigations involve blood. If we go hemoglobin less than 8 grams, rush factor negative, HBO grouping incompatibility is there, VDRL is positive, venereal diseases are there, HIV positive cases are there. We have to take care of. Definitely, the patient will deliver with all these things, but again, we have to take care of at the time of more careful about at the time of delivery for the patient, for the baby, and for us also. Blood sugar should be monitored. Urea, if blood sugar or urea is raised, and genetic screening to be done. Then urine should be examined for sugar and proteins and microscopic pus cells or epithelial cells present. If urine continuously remain with the infected urine, she will become anemic because of that only. Stool, if presence of worms are there, and for ultrasonography should be done in first trimester, then between 18 to 22 weeks because for biophysical profile, and in third trimester there's a choice of if somebody wants to go for or not, and the 34 to 36 weeks of pregnancy. Then what are the danger signs? Finally, vaginal bleeding. Once a patient comes to us, if she is having vaginal bleeding, she complains of swelling of face or fingers. If she complains of continuous headache, dimness of vision, abdominal pain, persistent vomiting, fever, dysuria, passage of fluid from vagina, marked change in fetal movements showing slowing or excess. These are the danger signs. Even patient when comes and complain of these things, we should take it seriously. Then the case for the causes are already we have discussed these causes during pregnancy. And one more thing is, if pregnancy is in unwed or unplanned pregnancy seeking MT, if they may come with a lot of say unethical practices which were practiced already to terminate the pregnancy. So we have to take care of that also. Then during labor, if it happens in uterine contractions are hypotonic contractions, sometimes hypertonic, sometimes irregular contractions are there. Pregnancy में तो सब कुछ ठीक था, बहुत बढ़िया चलता चला गया, but the labor के time पे suddenly it happens. And again we have to think of this, something must have been ignored during the antenatal checkups, or she may not have gone for that. Non-engagement of presenting part fetus after 34 weeks, and detection of abnormal presentation at the time of labor, or rupture of amniotic sac in first stage of labor. And excessive bleeding per vagina at onset of labor, prolapse of umbilical cord, hand or foot is there, delay or non-descent of presenting part. Sometimes what happens, patient comes to you first time, वो आया ही नहीं, पहले दिखाया ही नहीं, or sometimes it may be say overlooked, कि ऐसा हो गया है, और पेशेंट का आप सोचते हैं कि नॉर्मल हो जाएगा, इन योर ओपिनियन द बॉर्डरलाइन pelvis is there, it can come down, this can be there, बट उसका डिसेंड नहीं होता है, तो उसको इंतजार मत कीजिए, look from the abdominal side, don't look towards the only through vaginal examination. Normally this mistake is done by students. Normally this is done, they examine किया, देखा 2 फिंगर है, इतना है, but they never see for this कि descent fetus का हुआ है कि नहीं हुआ है. तो डिसेंड अगर फीटस का अगर वो नहीं हो रहा है, एब्डोमेन से पैल्पेट करके देखिए कि दोनों पोल नीचे चले गए कि नहीं चले गए. अगर पेल्विस में एंटर नहीं किया है, इफ यू आर एबल टू फील सिंगल वन पोल देयर, दैट मींस elongation of head is there, it's not descent. Pain and tenderness over previous operation scar if you find, that means scar rupture का हो सकता है वहां पे. Non-expulsion of placenta within 30 minutes of delivery, it is not there, that may be adherence of placenta somewhere. And after delivery, some puerperal problems like fever, high-grade fever is there, normal fever, cystitis की वजह से थोड़ा inflammation, थोड़ा reactionary fever can be there. If it is high-grade fever, she may have got some infection. Some then mastitis normally it is not dangerous, it is not a risk, but it is a risk if it enhances it, the purulent discharges are there. Then excessive bleeding if it is there after delivery, that is she is entering into the PPH, it is dangerous. Convulsions if there, preeclamptic cases में जहाँ पे कि बहुत say severe preeclamptic cases में जहाँ पहले convulsions नहीं आए, it can be after delivery also. And if uterus is inverted, जबरदस्ती खींचातानी की, अभी आजकल ये चीजें सब it is reduced because of more operative facilities. So but inversion of uterus, और आपने इसी को सोचते रहे कि ये prolapse हो गया, it's not like that, it has come down, so patient may go into the shock. Then management of normal pregnancy, how to manage the cases. In normal pregnancy, what we manage is dietary, we give dietary care, we give immunization, we give periodic examination, we tell to the patient, detection of normal growth of fetus we do, and high risk case detection is done. This is normal antenatal care, what is to be regularly, what should be done. Now in high risk cases, the care depends upon the specific risk factor, and care plans should include closer follow-up of patient, consultation with other medical specialists, अगर उसको diabetes है, hypertension है, cardiac abnormality है, some renal issue is there, or if she was having prior to pregnancy, all these things, or she has developed during pregnancy, we should definitely go for some medical specialists, we should consult them, and we should do it in collaboration. More ultrasounds and closer fetal evaluation should be done. Regular monitoring of vitals of patients should be there. Careful monitoring of medications used to manage pre-existing conditions, what she was taking before pregnancy and what should be given during pregnancy. There may be change of drugs. If health of mother or fetus is in danger, and termination of pregnancy or by induction or by C-section should be done, should be planned. Then final word is a high-risk pregnancy demands standard antenatal care, early identification of high-risk cases, effective counseling related to lifestyle, diet, regular careful monitoring and management of associated risks can help for successful management of maximum risk factors during pregnancy, labor and prenatal period. And finally, high-risk pregnancy should be managed at well-equipped obstetric facility to have a healthy mother and babe. Thank you for patient listening. And now I hand over the mic to the organizers. Any question, anything, if somebody wants to ask. And again, I thank the organizers. They have given me the opportunity to say, pay homage, pay Shraddha Suman to my revered teacher, मेरी श्रद्धा मैडम को प्रणाम.
Thank you, madam. Thank you very much. Will you stop sharing your PPT? So we will go with the question and answer session.
I think we can wait for 2-3 minutes and then log out. It will be 6:30.
Yes. Please put the questions if there are any questions. Participants. Are there any questions, doctors? Or I request all the doctors. You can directly unmute yourself and ask the question. Madam, please आपका जो PPT है ना उसको minimize कीजिए या share करना बंद कीजिए. Dr. Ina ma'am, are you there? Are you there, Ina ma'am? Yes, ma'am. Yes. Thank you very much. Thank you, ma'am. It was really nice session. Thank you. Yeah.
Thank you, Dr. Shilpa, for giving me time
Yes,
for,
ma'am. Thank you
for
very
this
much.
interaction.
Yes, yes.
Thank you
It's
so
a
much.
great pleasure to have here, ma'am. Thank you very much as a speaker. So, are there any questions, doctors, please?
So I think there is no question. I feel honored. I feel really honored because of Madam Tiwari only.
Yeah,
Today I am
bilkul.
feeling very honored.
Can you throw some light about the preeclampsia during pregnancy or hypertension? How to deal with that part according to Ayurveda, ma'am?
According to Ayurveda, we can say, because there are so many reasons for preeclampsia and hypertension. All are not related to diet and all are not related to your lifestyle. If it is related to your lifestyle and diet, definitely Ayurveda is going to help. We can help in prevention, basically, I should say. We can go for prevention. Once it is an established case of preeclampsia, it's an established case of hypertension, I think we should not put the patient on risk.
Yeah, definitely.
We cannot even. If we go for, the people will kill us. So
definitely.
we should go for preventive feature. We should, what I said, prenatal counseling should be there. And antenatal counseling should be there. What diet has to be taken, what type of diet should go, because everybody is not going to develop the preeclampsia if she is hypertensive. Everybody is not going to develop preeclampsia if she is having edema. Everybody is not going to have preeclampsia if she is having renal disease. But if she goes with the proper diet session thing and proper lifestyle, definitely. And for that, we have to give a full session. I think preeclampsia, somebody is speaking on it.
Definitely, ma'am. Definitely. Yes. Okay.
So thank you very much
Yes,
to all
good
the
evening,
organizers, to Dr. Pooja.
Yes, doctor. Yes, Dr.
Yeah,
Vaishali.
good
Yes,
good
is there
evening.
any question? Please, you can
Yes,
continue with
I
the
have one
question.
question.
Yeah.
Yes, ma'am, if a lady is having a history of preeclampsia in first pregnancy, so
Yeah.
what is the rate of risk in second pregnancy?
In in first pregnancy, the chances are more. In second pregnancy, the things are reduced normally. But if she develops, along with that, if she develops some, the previous pregnancy has developed, permanently she has got the hypertensive status, or she has developed some renal abnormality, she is again at risk. But we have to take care of that. We have to be very careful about that. I said preeclamptic state is not only because of diet or because of not only lifestyle. It can be some genetic factors also can be there. Some placental abnormalities also can be. The implantation of pregnant placenta is itself a cause. So we should not go by on the theoretical side only, but we should take care of.
Okay, what can be done to prevent, Ayurvedic point of view, what way we can do to prevent the preeclampsia attack in the coming pregnancy?
In the coming pregnancy, definitely we should go for that. We have to take care of our blood pressure. If she is not going on rising side, नहीं जाए उसको ध्यान रखिए. उसको डाइट का शेड्यूल दे दीजिए. Low salt. It should not be no salt. It should be low salt. It should be not fried, not heavy, not like junk food. Should not be given. Normal cooked, homely cooked food she should take. Lifestyle, she should have proper sleep. She should not sit with the suspended legs, so edema will come up. So she should not, she should be very careful about that. Anemia nahi develop ho usko. She should go for that type of diet with an additional iron, additional substitutes should be taken, whether it is from the government supplies or whether it can be from the Ayurvedic side. She can go for iron-rich food with simply with the amla rasayan and all these things. She can have beginning से उसको दे दीजिए, उसका वो she is going to have that. And then कुछ भी नहीं है, उसको काला चना बोलिए भिगो के वही को सब अंकुरित करके खाते रहो. Sprouted beans आप लेते रहो. They enhance the iron absorption, in fact.
Okay.
और उसके साथ साथ if she is having some renal problem that has to be taken care of, उसको कोई urinary infection नहीं हो, urinary वो नहीं हो, so that type of things you can give preventive measures, you can tell.
Okay, thank you, ma'am.
Yes, ma'am. Ma'am, hyperemesis के लिए कुछ बताइए आप, मतलब because I think
hyperemesis देखिए दो
many
status है. One
females
is
are go with up to 9 months.
hyperemesis का status ऐसा होता है कि एक status ये it is a gradual thing. पहले तो सिर्फ nausea रहा, फिर उसके बाद एक स्टेट रहता है कि जिसमें वो थोड़ा वॉमिटिंग होता है, जो खाया वो निकल गया और किया, उसको आप थोड़ा सा यू कैन मैनेज इट विद लाइक दैट, उसको घर वालों से अलग रख दीजिए, बहुत ज्यादा पैम्पर्ड नहीं रहे, एंड यू जस्ट गिव समथिंग लिक्विड इन फॉर हर, एंड उसके बाद उसको कुछ भी स्लीपिंग पिल देके उसको सुला देते हैं ताकि उसका सोए में खाना डाइजेस्ट हो जाए, एंड शी comes up to confidence, that confidence come into her. And another state is once she keeps on vomiting it at any stage, किसी के सामने भी नहीं है, कुछ भी नहीं है, तभी उसको vomit होता जा रहा है, and she enters into the say dehydration state. So definitely at that time you have to go for IV drips. उसको fluids दोगे, उसको dehydration को maintain करेंगे आप उस समय पे. And very rarely it comes to that state कि उसके बाद उसको इतना ज्यादा हो जाए कि आप उसको you have to terminate the pregnancy. But normally it is controlled by these things. And as far as in early stage is concerned, nausea है, vomiting है थोड़ा सा, that can be controlled with the diet schedule only. Liquid diet ले, frequent diet ले, 1.5 hour के बाद. I normally tell to my patients, हर 1.5-2 घंटे के बाद तुमको कुछ खा लेना. तो शी सेज कि नहीं मुझे कुछ नहीं खाने को मन करता है, नहीं मन करता है कोई बात नहीं, यू गो फॉर दैट. हर 1.5-2 घंटे के बाद यू गो फॉर सम फ्रूट, सम लिक्विड डाइट, सम लिक्विड, कोई सूप ले लो, कभी जूस ले लो, नॉट आर्टिफिशियल, नेचुरल जूसेस, नेचुरल फ्रूट्स, एकदम फ्रेश फ्रूट्स, fresh soups, fresh vegetable, whatever you can digest, whatever you like to have. लेकिन हर 1.5-2 घंटे के बाद आपको खाना है. कीप योर एब्डोमिनल स्टमक फुल, बट नॉट टू द फुल टू द एक्सटेंट कि आपको लगने लगे कि मुझे वॉमिटिंग हो जाए. उतना नहीं भरना है, खाली नहीं रखना, भरना नहीं है. सो वंस जूसेस आर एट देयर वर्क स्टमक के, तो वो कभी उल्टी नहीं होने देंगे. और जब जूसेस आप खाली छोड़ देते हैं, when acid is there, that reflux comes and he starts vomiting.
Definitely. Thank
Normally
you
it
very much.
happens.
Yes, yes. As a Rasayan, what you prefer, ma'am, as per your experiences, like some Ayurvedic preparations, because people ask like
For
some Ayurvedic
vomiting,
formula
for vomiting,
for
for
normal.
vomiting,
No,
for
no, for just
vomiting.
no, for Rasayan as a type
Amla,
presentation.
I prefer amla. Amal ki rasayan.
Yeah.
That is the best.
Yes, yes. Is there any question, doctors? We are at the end of the session.
गुड
Yes.
इवनिंग मैम.
Yes, Dr. Sarita, please continue.
मैम मैं मैम से पूछना चाह रही थी कि मैम
Yes.
जैसे एंटीबायोटिक हैमरेज है, उसमें आयुर्वेद के पर्पज में क्या दे सकते हैं हम?
देखिए, एंटीपार्टम हेमरेज का कारण क्या है, पहले तो ये देखना पड़ेगा. ठीक है ना?
यस मैम.
ठीक है ना? आज हम अपनी मैडम की यादगार में ये लेक्चर कर रहे हैं, लेक्चर सीरीज कर रहे हैं. तो एक चीज मैं आपको बड़ी क्लियर कर देना चाहती हूँ, जहाँ तक मैंने मैडम को जाना है, समझा है, मैं उनके साथ काफी एसोसिएटेड रही हूँ, काफी मिलती रहती थी, बातचीत भी करती रहती थी, फोन पे भी पूछती भी रहती थी उनसे. उनका एक ही ओपिनियन था, डोंट गो फॉर एवरीथिंग, डोंट इन सर्च ऑफ फॉर दिस थिंग. सब कुछ मुझे यहाँ पे मिल जाएगा, आयुर्वेद में मिल जाएगा, बस सब कुछ मुझे एलोपैथी में मिल जाएगा. इट्स नॉट लाइक दैट. गो विद द रियलिटी, एंड रियलिटी इज APH. व्हाट इज द कॉज ऑफ एंटीपार्टम हेमरेज? एंटीपार्टम हेमरेज का कॉज है प्लेसेंटा प्रीविया, द स्टेट ऑफ placenta where it is situated. Once it is situated, which is mechanical problem, which is a mechanical, purely mechanical problem, तो उसको आप क्या करेंगे किसी ड्रग के साथ? उसको तो मॉडर्न का ड्रग भी कोई नहीं कुछ कर सकता. और दूसरा स्टेटस है एब्रप्शियो प्लेसेंटा. एब्रप्शियो प्लेसेंटा कब होता है? जबकि या तो हाइपरटेंसिव है पेशेंट, या उसको कोई डिसऑर्डर, मेडिकल डिसऑर्डर कोई और है ऐसा, या उसको कोई चोट लग गई है. तो डेफिनेटली अगेन हियर मेडिसिन आपका क्या करेगा? हाइपरटेंसिव को जरूर आप प्रिवेंट कर सकते हैं, आप उसको डाइट शेड्यूल दे सकते हैं, थोड़ा सा एंटी हाइपरटेंसिव उसमें ऐड करेंगे. बट डेफिनेटली इफ शी इज हाइपरटेंसिव, यू आर नॉट गोइंग टू गिव एक्सपेरिमेंट विद दैट पेशेंट. आप उसका डाइट शेड्यूल देंगे, उसको भी करेंगे. इट इज नॉट ऑलवेज विद दी हाइपरटेंसिव. एक्यूट हाइपरटेंशन में ऐसा होता है, नॉर्मली थोड़ा सा स्टेटस है तो उसमें नहीं है, तो डाइट शेड्यूल दे देंगे आप उसको. इफ आई से कि I can prevent antepartum hemorrhage by giving some hemostatics, that is wrong, absolutely wrong. Bed rest is the solution. Go for bed rest. Nourishing diet usko dete raho, that is the thing. So this is a mechanical issue.
थैंक यू मैम.
So hi Shilpa, can we leave? Hello.
Yes, ma'am. Yes, yes. Just a minute. Asha ji is there. आशा तिवारी जी मैडम है यहाँ पर उपस्थित है. Is there anyone from
Family?
Hi, yeah. Is there anyone from family? Because
I think Dr. Asha was there, but
yeah. Okay. Yeah. So I think all the questions are covered. Just one last question is there. स्प्राउट्स के बारे में आप क्या कहेंगे? अंकुरित अनाज के बारे में.
सॉरी, किसके बारे में? हेलो, डॉक्टर शिल्पा. हेलो. शिल्पा,
Yes, ma'am.
हाँ, क्या क्या कह रहे थे आप?
स्प्राउट्स के बारे में, अंकुरित अनाज के बारे में बताइए.
अंकुरित अनाज इज वेरी गुड. वो आपको जब आप वो खाते हैं तो दैट एनहेंसेस, दैट हैज मोर ऑफ द विटामिन सी इन इट, और उसमें दैट एनहेंसेस आयरन अब्जॉर्प्शन. तो इसलिए स्प्राउट्स आर वेरी गुड. वो उसमें जो प्रोटीन कंटेंट आ जाएगा जब आप स्प्राउट्स देंगे, स्पेशली काला चना और मूंग जब आप देते हैं, दैट इज रिच इन प्रोटीन एंड दैट एनहेंसेस द आयरन अब्जॉर्प्शन आल्सो. So, hello, Shilpa, are you there? So,
Just a minute. Is there any question, Dr. Sangeeta? Dr. Sangeeta Deshmukh?
Yes, ma'am. I asked about the oligo and polyhydramnios, both status. What should we give and what should we avoid for that?
in case still it is in a thing of research, I should say, but in oligohydramnios case, we have tried so many things. So it works to some extent, but we are not sure about कि वो पूरा काम सच्ची में उसी ने किया था, because we have very less cases with us. 10 या 15 केस के बाद आप you cannot say कि this is absolutely working, but still we had something. We gave Sariba, we gave especially we gave this thing. I'm skipping my name of it. Yeah.
Okay, ma'am, no issue.
It's not in our place. Basically, we got it from hot areas. Somebody can, if Ritu is there, she can tell. Ritu Pandey is there.
Yes, Dr.
Gambhari.
Ritu?
Yes,
Are you there?
Gambhari.
Gambhari,
So
okay, okay.
Yes, we Gambhari we gave. So we gave Madhyashti also. We gave a combination, but it was good, no doubt. We tried it, but the number of patients were very less, so we cannot say exactly it was there, but definitely patient Devika weight improve hua tha, and status of amniotic fluid was also improved. That can be naturally also, and that can be because of the diet schedule also. So rest
Yes,
mila,
yes.
patient को rest मिला इतना, उसको hospital में सी रही, and उसके बाद घर में भी जाके रही. That can be the reason also again.
So, is there anything like in Masanumas Vruddhi that it should not happen? So, like
few things are when the cause is not clear to us. अभी पता ही नहीं है कि होता क्यों है.
हाँ हाँ.
है ना, जिसका कॉज नहीं पता है, कारण नहीं पता है, तो उसका कैसे करेंगे? उसको जब तक किसी चीज का कारण ही नहीं पता होगा, उस कारण को ही तो हटाना होगा.
Yeah.
हाँ, उस कारण को ही तो हटाएंगे. कारण नहीं जब तक हटा पाएंगे तब तक कैसे?
Yes.
Dr.
Likewise,
yes, sir, Dr. Pradeep. Yes, ma'am. Yes. Dr. Pradeep, sir, please. Your hand is raised, so please ask if there are any such question. So I think he left the meeting. So now coming to the end, I request Dr. Joshi sir, Dr. Naveen Joshi sir, who is the founder of this Ayush Darpan platform, I request him for vote of thanks.
Thank you, Vaidya Shilpa Ermeji. It's a very immense pleasure that we are organizing a series on gynecology on the memory of late Vaidya Premvati Tiwari, madam. And I welcome and I am giving thanks to all the participants as well as the guest speaker Vaidya Ina Sharma ji for this opening special lecture on identification of the high risk pregnancy. मैं आप सभी से अनुरोध करता हूं कि इस लेक्चर को आप अपने फेसबुक लिंक पर, ये सेव है, वहां पे आप देख सकते हैं। आगे ये आयुष दर्पण के यूट्यूब चैनल पे भी रहेगा और आयुष दर्पण के डिजिटल ऐप पे भी अपलोड किया जाएगा। तो ये जो लिंक है उसको आप अधिक से अधिक शेयर करें, क्योंकि देखिए गायनी की स्पेसिफिक सीरीज जो है वो बहुत कम होती है। आपने बहुत सारे लेक्चर्स देख रहे होंगे यहाँ मैडम, पर हमारे यहाँ पे जितने भी यहाँ पे वैद्य लोग हैं, मैं उन सभी का स्वागत करता हूँ। और सबसे बड़ी बात है, यहाँ मैक्सिमम जो है वो महिला चिकित्सक हैं। अंजना मैडम जी हैं यहाँ पे, मैं देख रहा हूँ। और इतना अच्छा ये सेशन रहा, मैं उम्मीद करता हूँ कि इसको महिलाओं चिकित्सकों के अलावा पुरुष चिकित्सक भी इसको एंजॉय कर रहे हैं, गायनी के सेशन में उनका भी इंटरेस्ट आ रहा है। तो मैं बहुत बहुत दिल से आप सभी का धन्यवाद करता हूँ। विशेष रूप से आज की जो स्पीकर है वैद्य ईना शर्मा जी का, जिन्होंने आइडेंटिफिकेशन ऑफ हाई रिस्क प्रेगनेंसी पर इतना अच्छा व्याख्यान दिया, बहुत बहुत धन्यवाद। आप सब आयुष दर्पण का डिजिटल ऐप जरूर डाउनलोड करें और उस ऐप पर जो ये गायनी के सेशंस हैं उसका एक बैच कोड है, वो आपको इस लिंक के बाद शेयर किया जाएगा व्हाट्सएप ग्रुप में, उसमें आप ज्वाइन कर सकते हैं और वहां से आप इन लेक्चर्स को देख सकते हैं। बहुत बहुत धन्यवाद, प्रणाम।
थैंक यू सर, थैंक यू वेरी मच। तो इस प्रकार से स्वर्गीय प्रेमवती तिवारी जी के स्मृति के उपलक्ष्य में हमने इस सीरीज को ऑर्गेनाइज किया है। तो अगला सत्र जो है, देयर आर सो मेनी highly qualified speakers are there around, मतलब over the India. So next जो नोटिफिकेशन होगा हम लोग भेज देंगे आप सभी को। और इसी के साथ आज का ये जो सत्र है तो इसको हम लोग यहीं पे समाप्त करते हैं। नेक्स्ट सेशन इज ऑफ वैद्य कामिनी धीमान मैम on 20th February. I think the topic is very much interested, pre-marriage counseling need of the era. So we are dealing with this topic again and we will meet again on 20th February. So thank you very much all. नमस्कार सभी को, आभार। Thank you ma'am, Ina ma'am, thank you.